the end of this month, he will do the second follow-up. So for the in my next case, it was an 80 years old stable diabetic presented in January 2019 with 1/60 vision and boggy macula with subretinal hemorrhage, and on OCT there was multiple PEDs with multiple sister changes. CNVM is appearing in the neurocystic retina, you can see. After giving 6 injections of ranibizumab and 2 aflibercept in the left eye, patient in the month of September, patient's CNVM condition was almost stabilized and vision improved from 1/60 to 6/24. And again, that appeared, there is appearance of large sister changes in the month of October end this year, and vision dropped down 1 line at 6/24 parts. And then I advised him, it was almost like a recurrent case, so I advised him for brolucizumab. And after 2 weeks of giving brolucizumab 6 milligram in the left eye, there was total disappearance of cystoid changes, you can see here, as well as the CNVM part is not disappeared, but still the PED scenarios has come down quite significantly, and the other changes are also looking stable. As brolucizumab is quite like long-acting, so I advised him for after 2 weeks he should come up. Like after this is after 2 weeks, only 2 weeks. So I advised him to do the follow-up after 2 weeks. He will do it the next week. So this is these 2 cases were my initial first experience among my that case.
Thank you so much, Dr. Subhendu. Can I request Dr. Sudipto Das to please moderate?
Thank you, sir. I think I would like to thank Dr. Boral also for this nice presentation on these 2 cases. I would request Dr. Pal, Dr. SS Pal, if he's there, just to discuss maybe in few lines about these 2 cases, and then we can take few questions on this. Dr. Pal is there?
Saksha? No, I think should we just go ahead?
I'll just go ahead. So I would first ask Dr. Boral maybe two questions on this. Maybe we can have opinion from the panel also. That before you planned of giving these 2 injections, what were your apprehensions about this starting this new molecule, and especially in the first case where you have a treatment naive patient?
Especially like in the from the other studies, from case reports as well as the subgroup analysis, whatever is quite evidence of quite alarming for many of us, that all of us, that incidence of intraocular inflammation, uveitis, as well as the incidence of RV, retinal artery occlusion. So these 2 factors were really, and frankly telling you, it was the incidence was quite low, and that was mainly the matter of concern. So I repeatedly every week I just rang up the patient, what is his visual test, and is there any sudden loss of vision, because we have seen from the report that appearance of choroidal ischemia and the loss of vision is there, but still the evidence of periphlebotitis and the inflammatory changes in the arterioles that actually spontaneously disappear. It generally appears at in the month of 6 to 8 weeks and disappeared by the 2 to 3 weeks with the topical steroid drops only. So these are all antigen antibody reaction, type 4 antigen antibody reaction. That is the vasculitis part. And intraocular inflammation was maybe it is easily treated with the topical steroid. So that's why I was repeatedly calling the patient every week, whether are you okay? If you cannot come, my counselor.
So I think what Dr. Subhendu was telling, I will just ask our panel, Dr. Saraf, Dr. Chattopadhyay, Dr. Mondal, that if you are planning to give this injection, do you have anything in mind regarding follow-up of these patients, or do you have anything specific in mind to counsel these patients before giving injection? Our August panel we have. Can you have any of the panelists?
I understand there can be some.
Yes, sir. Yeah, Dr. Saurabh, please.
After this injection, so that is the concern. So how do you deal with that?
Sir, I have a point to make over here. I think Novartis has gone on overkill, scaring the hell out of us about this arterial periphlebitis and things. This, if you analyze that correctly, the numbers that they have shown is per 10,000 injections. It is a projection that they have made of the injection numbers they already sold in Europe and America, vis-a-vis how many injections they've had. They have the in number, actual numbers, nobody still knows. So it's a very hypothetical situation right now.
Right.
I do accept that even one case is a disaster for the treating surgeon, but the numbers that are shown over there are not actually the way it's been portrayed to us. I believe we've already crossed a few hundred injections in India. There's been one reported case up till now.
That was also doubtful, like it was
That
a
was also
post-operative, post-cataract surgery. It's
So we need to be careful about it. I agree with Subhendu when he said he called the patient again and again, because at the back of the mind is always there. It doesn't work, it's fine. But if it causes inflammation, you're really done. So that's, I think, I agree with that. Professor Ghosh, sir, any concerns? New drug?
Dr. Boral, please tell me, you have told that there is some complication like arterial occlusion. Have you gone through any report that has been written in a journal, or
Yes.
and which artery commonly affected?
Yes, sir. AJO case report, there was a report of like arterial occlusion, but that patient was treated with a topical steroid. And there was that arterial occlusion appeared at the month of 8 weeks after giving injection, and that spontaneously resolved after 10 weeks. At 10 weeks, it was totally resolved.
In that situation, etiopathogenesis of arterial occlusion.
Basically, it is telling
simple arteritis.
No, not arteritis. Basically, it is a very small drug. Yes, sir. Yes, sir. Maybe it is kind of uveitis. That is a separate thing. But for the kind of like arterial occlusion, that was a delayed hypersensitivity type 4 antigen antibody reaction. Basically, the drug is penetrating within the retina at a higher like number of moles per unit volume is very high.
I will come to that.
Size of the molecule. So that is why there are more molecules of bronchiomas is entering into the retina. So that is causing the antigen antibody reaction.
Can I
point from
sorry, can I interrupt? Is Ajitabo there online? The Novartis representative scientific presenter? Is Ajitabo there? Because I believe they had the recently concluded European Society meeting in which the European group has put up a poster and a presentation there, which had a vigilance group on these numbers and what they have done. So they have not published as yet the thing, but they have had a poster. Is Ajitabo, anybody know what is there?
Yes, Shrutani is there.
Shrutani, can you guide us on that?
Yes, sir.
Can you give us a guideline on that? What has happened? What presentation?
So, sir, what we can just tell you in front of in a very brief that there is a website called brolocizumab.info. So that is already available in the public domain. So it shows that if 10,000 procedure is happening into the globe, so there is a 14 case of total adverse events been reported for last 2 months. So it is every month they are updating it. So as of now, the entire rate is 14 patients. Out of that, retinal vasculitis is 5.13 patients. Retinal vascular occlusion is 3.22 patients, and other inflammation is 6.12. So overall, 14 patients out of 10,000 have this type of inflammations. I think Ajitabo can give a better idea.
Yeah. Can we stop and take Dr. Borah, sir? Any? You've been around for a long time. What is your comment, your take on this new medication? Why have you not used it? Why have I not used it? Let's get your perspective.
It's a new medicine for us. So the first time I have heard it about 2 years back in academy, but then I haven't used it personally in Northeast. I have some issue like it has been mentioned that it can cause some retinal problems, although it is very rare reportedly. But the point is, we have 2 medicine in our hand. One is approved and one is not approved, and we rarely use the third medicine. And this medicine, our issue is whether we need to do any other systemic investigation before going ahead for this, like arterial occlusion and any branch vein occlusion, anything else. These are certain questions are there, so we are rather hesitating using the medicine. Probably we'll go ahead within a very short time, but still we want to see what are the issues which might turn up in near future.
Do you use, how much of ILIA do you use, Dr. Borah? ILIA, how much do you use?
No, very few. We use mostly Lucentis, approximately say 20, 25 cases. Lucentis.
So you're not doing much of ILIA also?
No.
So Dr. Sudipto, I think Vedang has, can I ask a question?
Yeah. Sure.
Chat box.
Yeah. Thank you, sir. Just wanted to know, sir, whether we should measure the IOPs frequently, because in all the studies, all the papers, nowhere intraocular pressure is being mentioned. So is there a criteria that we should, one of the criteria we should be looking at?
My question back to you is, for your ranibizumabs and your, do you measure IOP?
Sir, I do it at 2 weeks.
You do measure IOP for ranibizumab?
Yeah, post because when we are talking about retinal arterial occlusion, so initially on the table I do check for digital.
No, they have not talked about the arterial occlusion related to the intraocular pressure changes. It's more of what Dr. Boral said, immunological reaction kind of a thing.
Yes, sir. So, but I'm just asking, just my hypothesis, whether we should do IOP evaluation.
I just wanted to add, Vedang, probably till date, whatever evidence we have, maybe we can straight away avoid these injection in patients of inflammatory CNVM, where we have a past history of uveitis, and maybe a in-between follow-up, because most of the occlusions occur after 10 days. Maybe after the first day, instead of having a monthly checkup, we can have a 2 checkup in between, maybe at 2 weeks, just to find out whether we have any.
Right, Sudipto.
No, one sec. Subhendu, can I ask you to unshare and Vibhuti to come up, and Subhendu, carry on. Please go ahead. Boral, please go ahead.
Dr. Sudipto was telling that is 2 weekly follow-up. Trying to follow up. Not after 10 days. What he is telling that after 2 weeks, like 2 weeks, the follow-up should be, first follow-up should be 2 weeks. But you have to always be in contact with the patient.
Saurabh, can I have a question?
Yeah.
Hello.
My first request, everybody has to mute themselves, and only the person speaking can mute. Dr. Borah, please go ahead. We'll take Dr. Subrata, Mondal, Dr. Abhishek, Kedia comments, and we'll move on to the next case, please. Dr. Borah, please go ahead.
My question is to Dr. Boral. So the checkup after 2 weeks, I mean, what is the exact logic put forward by the company for checkup after 2 weeks? Is there any other particular reason for that?
No. Dr. Borah, this is Dr. Boral's apprehension that he was being careful. There is no recommendation as such, if I'm not mistaken. No recommendation.
So what is your take? How do you suggest the post-op follow-up should be? I mean, because it works for a long period. So how do you go for your patients after injection?
Like after injection, first follow-up should be done at 2 weeks, second follow-up at 4 weeks, and you can do the follow-up after 3 months also.
And you do all checkups, including intraocular pressure.
Or 3 months, or after 1 month also. At like 2 months.
Yeah. Okay. Dr. Kedia is there. Dr. Abhishek Kedia. We'll then move on to the next case.
Yes, sir. Good evening, everyone.
Abhishek, hi, welcome to our meeting. Any comments, any queries, any?
Yeah, the part where I practice, the money is the most important factor. So why I gave this injection to patient was that
Abhishek,
sorry,
you're not audible. Yeah.
Why I gave the injection to the patient was the time duration, like because it acts for 2 to 3 months, and the relative cost, it's a little bit cheaper than the other option, which is longer acting. So that was the reason I gave it. I would like to know the house opinion on why they choose it over other longer acting molecule.
I think it's a beautiful point you've made. This is something that we don't look at, and I keep telling this to my Why sometimes in diabetics, bilateral eye disease, multiple injections, I talk about switching to Ozurdex. If you give Ozurdex 3 injections in the whole year or 4 injections, it's cheaper than giving any other anti-VEGFs. So I agree with your point. This is a different way of looking at the whole situation of longevity versus price. I think this is one point. Is Dr. Subrata Mondal there? And ma'am, Dr. Premata Kapoor, your last comment, ma'am. We'll then shift to the next slide. Bibhuti, can you please share your screen, please, Dr. Kashyap?
Yes, sir.
Ma'am, Dr. Premata Kapoor, ma'am, any comments, queries? Is Dr. Premata Kapoor there, ma'am? Okay.
Can you hear me now?
Yes, ma'am. Please go ahead.
Yes.
My concern also is ocular inflammation, retinal vasculitis. I would like to wait for some time and see the result and then start. When we have alternative.
I wrote my comments on that. I think only time will tell us, because we've all gone through the Razumab story also of inflammations. Ozurdex did work for 6 months, now works for 3 to 4 months. So I think the Indian experience, and I respect your judgment on that, and I respect our Subhendu for having done the first 2 cases also. Thank you so much, Subhendu, for sharing with us. So nice of you. We'll move on to Dr. Bibhuti Kashyap. Bibhuti is practicing at Ranchi at his own hospital. And Bibhuti, please take it away from here.
Yes, sir. Good evening, everyone. Am I audible and visible with my screen?
Yes.
All right. So good evening, everyone, and pranam to everybody, because I think I'm the junior most sitting over here. So I'll just straight away start off with my case. This is a case presentation of my first experience with brolucizumab. So my case was a pretty tailor-made case. He was a 62-year-old gentleman presented to us on the 8th of October with diminished vision in the left eye since 1 year. He was an already diagnosed case and treated case of wet ARMD. So on examination, his best expected visual acuity was 3/60. The anterior segment findings were not that significant apart from a very early cataract. So the patient had a wet CNVM. He had a history of 5 doses of intravitreal ranibizumab monthly since May of 2020. And this is what his pre-op OCT looked like. There was an obvious amount of activity that was visible in most of the lines of the OCT. So the plan was to give intravitreal brolucizumab and a topical anesthesia. And the patient behaved well. There was no undue side effects or the adverse reactions on the first day. On the first week. On the 7th day, the patient responded pretty well, and there was a very significant reduction in the IRF as well as the SRF. These are the comparative pictures of that patient. This was taken on the 7th day of the injection. The patient came back at the 7th week, and on his follow-up, his BCVA had improved to a 6/24 parts, and there was no evidence of intraocular inflammation. And these were his line scans sequentially. You can see there is persistence of a dry state in the macula. There is no evidence of activity. There's a pretty clean, flat macula with the regression of CNVM. Thank you.
Thank you, Dr. Bibhuti. Very nice and concise presentation. Very neatly done. Good presentation. Thank you so much. Can I ask Dr. Sangeeta to please take over?
Thank you, Bibhuti,
Thank you, Sangeeta is a retina consultant at Chattopadhyay Hospital and my go-to person to always bail me out. Thank you, Sangeeta. Please go ahead.
Thank you, Bibhuti, for the presentation. May I please request the panelists to please discuss the case. So Dr. Kumar Saurabh is there, Dr. Kashitiz is there, Dr. S.P. Tiwari is there, Dr. Anshuman Sinha is there, and my very dear junior, Dr. Subodh Singh is there. Dr. Vedang Shah, are you there? Dr. Vedang Shah?
Yes.
So you can start the discussion. On the outset, I just want to ask one question. So how many of us would prefer, there is a choice of either Eylea or aflibercept or brolucizumab in this patient, these kind of patients. So how do you make that choice? Whether to give Eylea or Paginex?
This is to me, ma'am, or to everybody?
To everyone, to you, to everyone. Okay.
And so when this patient came up to me, this was a pretty biased decision to be very honest, because I was itching to try this new drug as it had gotten a new FDA approval. And of course, all the studies that they have, the studies that are there to back this drug up are obviously showing a superiority of brolucizumab to aflibercept. So, I mean, I use that as a facade to use brolucizumab. Otherwise, I mean, there have been adverse drug reactions to this brolucizumab, but there are also papers who are citing it the otherwise. They're saying it's a nocebo effect, because as we know, the ASRS alert on 23rd of February 2020, when they said there is a possibility of this vasculitis, they had 14 patients in 46,000. They had serious effects. But that amounts to 0.03%, which are pretty much in line with the inflammations that we have with bevacizumab or ranibizumab. And if we know, ranibizumab also had a rate of 10% inflammation when at the time of its launch, which of course reduced with the introduction of ultra pure polysorbate 20 into the filtration process. But yeah, so I mean, I just thought, why not? It's a tailor-made case. He has had history of 5 injections of ranibizumab. There is no resolution. The patient is unhappy. I have a patient. I have the backing of the study. So why not brolucizumab? It obviously shows its superiority over aflibercept. So why not go and give it a shot?
Okay.
Dr. Bibhuti, there is another post hoc analysis that states or compares aflibercept with brolucizumab.
Yes.
So would you like to share that?
Yes, so I actually have it in my presentation. If I'm allowed to share my screen again, I can run you through the.
I have a point here, guys. If you are presenting, then मैं क्या present करेगा? So no, I please go ahead, Bibhuti, and let's get your data.
Sorry, sir, it's okay, sir. I'll just speak out.
Lock it off here. I won't show it there. You will lock it off here itself.
No, sir, it's okay, sir. I'll just discuss in brief. So basically, the aim of the post hoc analysis of both the Hawk and the Harrier, both of them were 3-pronged. The first was that we need to see as to how many injections do we need to attain a dry macula, and secondly, how quickly we attain a dry macula when we compare aflibercept to brolucizumab, and we need to see the cumulative incidence rate of a dry state at weeks 14 and 96. So these 3 were the aims of the post hoc analysis in both Hawk as well as the Harrier. So what they got to know was that not the 50th percentile, but the 75th percentile of the macular dryness was attained with aflibercept as well as brolucizumab. But with brolucizumab, it required significantly fewer injections, and it reached the dry state significantly earlier than aflibercept. And the exactly same finding, although the numbers may be variable 1 or 2, but the same finding was there in the post hoc study of Harrier, as well as when we look at the cumulative incidence rate of the dry state, of course, the 6 mg brolucizumab had a superior result to aflibercept in both the Hawk and Harrier post hoc. So it had a greater incidence of, dry macula. So those are the two basic outcomes of the post hoc that we intend to look at when we choose. So backing those studies,
So those of you who heard him, I shall not speak about this again. If you missed it, bad luck. He summed it up very well. Back to you, Sangeeta. Anything else with your panelists, please, about this case itself?
Actually, any comments from the panelists, Dr. Saurabh? Yeah, Subodh, please. Dr. Subodh, please.
Yeah, thank you, Dr. Sangeeta. Actually, your question is very clear that if you, your question is very straightforward. If you have given options to give a brolucizumab with aflibercept, so we need to answer that why. Well, what will be our options to choose? So I'm going through the literature. What I saw that brolucizumab is like much more like in comparison to aflibercept, that what we need to be the clinician while treating, what we want to see is that the drying stage of the wet RMD, and that is what we are getting in brolucizumab much more better than the aflibercept. Second is that the number of injections required in this brolucizumab is lesser than compared to the aflibercept. It's a 3 monthly injections, and that one is a 2 monthly injection. And third is the like it's cheaper than the aflibercept. So going through all these, the brolucizumab will be the first option. Again, yes, the side they have been quoted, and in the literature also is very, very less. We need to take care of all this. We need to see the side effects, and if with the long-term treatment, we only say that whether we can go ahead with this brolucizumab or not. But for me, in the going through literature, brolucizumab in the near future will be like is a good choice compared to that.
My Sangeeta, no, Vibhuti, hold on, Vibhuti, hold on, please. Yeah, Sangeeta, take it ahead. We already at 8:40.
Yes,
we have 3 more presentations and mine also.
So
I don't need to
there's
disrespect
one question in the chat box from Dr. Subodh. He is asking how late can the inflammatory reaction occur post injection. So, Dr. Saurabh, do you have any comments?
No, they said up to a month. They've said it up to a month. Can we go ahead to the other panelists and we close the session after that, please?
Yes.
I have a quick question to Dr. Bibhuti. I'm Kumar Saurabh. What is the status of this patient now? Means how is the vision and how many months have been there since the first injection?
So this 7th-week follow-up was done today itself.
So he is holding on good until 7 weeks.
Yes, sir. He's the last sequence of OCT that I showed was as of 11:35 a.m. of today.
So how are you following up?
So I am following him up monthly. And the reason, and as the previous questions were asked regarding intraocular inflammation, my main stress and my main worry is about the vasculitis, although I also think it's a kind of nocebo, but it won't harm to actually keep track of any kind of anterior segment inflammation also, which may in future lead on to a vasculitic event in the posterior pole. So
Yeah.
that is how I'll be following up regular pressures and inflammatory checking and OCT.
So now what I was rather asking about is that when are you going to consider repeating the injections? I mean, how long do you expect that the effect will remain? The fluid will come back.
If we quote study wise, there has not been a study to show what happens if we do a PRN dosing from the very beginning itself. There has always been a monthly dosing pattern. So we don't have a template exactly how to follow. So what I do with all my patients is what I'm going to do with this patient also. I'm going to follow him up just monthly, and whenever and wherever he has a recurrence of the fluid, I'm going to re-inject him.
So we are creating real world data over here right now.
Sorry, sir.
We are creating real world data right now.
So the real world data is just
real
my
world data.
It's almost 2 months.
Sangeeta, can we move on?
Yeah, so any comments from Dr. Kshitij?
Just one quick comment as to the question of Dr. Subrata. Most of the they are, they found intraocular inflammation as late as up to 3 months. So I think the 3 months should be an ideal cutoff. We should have follow the patient very closely for first 3 months at least.
Yeah.
Thank you, sir. Any comments, Dr. Anshuman Sinha, Dr. Tiwari, are you there? Dr. Tiwari, are you there?
Yeah. Just I wanted to add a point that regarding that option of aflibercept and this brolucizumab. Last month I injected one patient. He received first injection as aflibercept, and the second injection, one-eyed patient, I have given second injection of brolucizumab. I am yet to follow at 1 month. So let's see what is the outcome, and then I can compare my patient. First injection aflibercept, and the second is brolucizumab, and then I can come up with some data.
Dr. Sinha, do you have any comments? Dr. Anshuman Sinha?
Yes, ma'am. Hi. So I've given 3 brolucizumab in all diabetic patients, so off-label use. And for CNVM, still I use off-label aflibercept also. So I have patients who stay dry for at least 2.5 to 3 months on aflibercept off-label as well. Diabetics, as Dr. SSA told, that the cost as well as number of visits an issue. So I personally feel as of now that it may be a better idea in diabetic patients to reduce the number of follow-ups. For AMD, I'll see if other data, how they respond, how long it holds. If it goes more than 2.5 to 3 months, then I'll consider about approved indication of brolucizumab. As of now, I am still continuing with off-label aflibercept in AMD.
Thank you.
Yeah.
Thank you so much.
So we will go to the next session, and Dr. Vedangsha, if you have any closing comments, then.
Thank you. I think most of it has been covered, and I'll pass on to Dr. Saurabh, sir.
Sir, please. Thank you.
Yeah. Are my slides visible?
Yes.
Yes, sir.
Yeah. So is Dr. D.N. Chattopadhyay, sir, there? Dr. P.N. Vishesh is there, sir? With the permission, and with Dr. S.U. Ahmed from Assam, Dr. Kajulda, I know was there, Satyen Deka, Arnav Das, Shalabh, Pooja just came on. Rupak Roy cannot attend, he told me that. Rupakanti Vishesh. With your permission, I'll go to my presentation. And we are running horribly late, so I will rush through my slides. There is hardly anything which you already discussed already. And I blame Bibhuti for that. Thank you so much, Bibhuti, for making my work easy.
Sir, please don't embarrass me more.
No, I just putting you. You're the junior most guy. I have to blame somebody for my poor presentation. So quickly, I come from this era where I started PDT. I was part of the first PDT under Shankarathan in 2001. And it used to cost 1.2 lakhs at that time. My first PDT, some of them are still follow up in 20 years after later. I still think one of the best treatments I ever did. One PDT and they stood still. Some of it's 618 still today after 20 years. I am an old guy and I still think PDT was a great treatment. I blame Novartis for pushing it out right now. Anti-VEGFs, I started off in Calcutta along with everybody else here in 2006 October, and this is where we stand today. This is a little confusing slide. Basically, we all have these things. Patient is diagnosed, fear of injection, then you on follow-up, patient doesn't come, patient prolongs follow-up, rebleed, other eye happens. This is what we all go in the current scenario is what we are happening. These two, I was around when they published, an anchor, what told us monthly injections the whole year through. So I think as we go ahead, as we learn our practices, this wasn't the best option possible. But it did show us that we had some option to treat our patients. Along came, and I was a little surprised when I see this. 2012, View 1, View 2 were published. I was a little taken aback. I didn't realize that. So that means technically, ILE has been around for 8 years. I've been using it only for the last 2-3 years pretty well. So I'm just trying to bring back to you that now ILE has been around for quite some time. Of course, real world analysis, like Dr. Bibhuti said, using it for a patient. Brolucizumab used in a naive patient by Subhendu. We got one presentation and a different take on the whole thing by Dr. Bibhuti, contrasting viewpoints, both agreeable by me. And the real world analysis shows that of course, what this group told us, this Raman Teodeni from France and this Hall's group, that when you give lower treatment frequencies, vision is poorer. We all know that. So basically what we are all doing, the lesser number of injections, the lesser number of the outcome. I'd like to draw your attention only the topmost what concerns most of us, economic burden. Baki sub we can take care of. Follow up, this, that, long distance treatment. Of course, lockdown gave us a bad time. But for us in India specifically, this red one on top is what concerns all of us. Unfortunately, we take decisions sometimes on behalf of our patients ourselves, thinking that the patient can't afford it, which we do make these mistakes once in a while. So we have this ASRS PAT study, which again, essentially, I'll just go through the whole thing saying that reduced treatment burden is the main problem for all of us, whether US or elsewhere also. And all of us want to have something which is a long-acting, sustained delivery, which Anshuman beautifully said he uses it for diabetic patients. He's already jumped the gun and I totally applaud him for doing that. So basically, all of us want something which would work for a longer time and patients to come back lesser to us and is cheaper. I use the last word myself. This discontinuous treatment, treat and extend, PRN are words we've all learned in the last 3, 4, 6 years right now. But we know that patients, when they miss their the treatments, the results are always poorer, which is what everybody thought at that time. So coming to brolucizumab, one slide I will add over here. I wanted to go back because so much of COVID vaccine. So normally you have 3 phases, phase 1, 2, 3. Phase 1 of any drug trial is a small group of people looking for side effects. Phase 2 is a larger group of people looking at side effects. Phase 3 is when you're comparing it to a placebo or to a standardized treatment. This is what phase 3 is all about. Phase 4 is this post-marketing survey, which of late Eylea has been doing pre-COVID to us, ask us, give us a feedback on what we're using about Eylea. And just to give you a background on what happens, this is, so just to let you know that for a drug to come to the market to in our hands, it takes nearly 7 to 8 years on an average, 7 to 8 years. So basically you have to think of a drug, that's called the preclinical part of it, that takes nearly 2 years. You have an investigational new drug, you go ahead and think about it, then it goes to phase 1, 2, 3. By the time it comes out, it's a new drug application, and then it goes to phase 4. So it's nearly a 70-year period. So drugs don't just jump out into our pockets, into our market just like that. There's a lot of research which goes behind that. This is a little difficult one. This is I hate these kind of slides, which confuses things for me. But I will shift to this slide here. This is something which is familiar to us. This is the large antibody by itself, FAB region, FC region. I always mug up these kilodaltons before every presentation. 150 is here. The brolucizumab is a single chain fragment, which is a smaller thing, is the electron microscope over here. And the only thing I wanted all of you to concentrate on is 26 kilodalton. This was referred to by Dr. Bibhuti as this small size of it. Penetration is what motivated him to use the drug. Way back in 2016, that's 4 years back, it wasn't called brolucizumab. It was called RTH258. And this group did a 6-month study and compared it to ranibizumab. So this was a first in human study, a human study done at that time. So 6-month phase 1-2 prospective study was this. So this is the first publication initially of brolucizumab way back in 2016 when I had not even heard about it. The name wasn't available at that time. Of course, one of the later publications, recent publications, of course, we had the Hawk and Harrier, which gave us the landmark studies. But this is being initially published in 2020. What, and I allow to this today's presentation is, what's a single chain antibody fragment, SCFB? This represents the smallest functional unit of antibody that still retains its full binding capacity to its target. I normally don't like to read out statements, but I read it out again. Smallest unit of the antibody that retains its full binding capacity. I hope we're not wrong on this. Of course, I would love somebody 5 years down the line to bring up another molecule smaller than this and make life easier for us and our patients and cheaper for them. So till recently, we're only showing these 3 parts. This has been added, this last brolucizumab has been added over here. I will only allude to the fact this is 26 kilodaltons, others are much larger size. And this is what Dr. Subhendu was referring to when he said that highest molar concentration per injection. This is what Subhendu mentioned 2-3 times over there. This is what he's talking about, hoping that these injections are superior to the others. Hoping. So when you give the injection here in the vitreous body, the penetration, because it is small, and the time it is penetrated is much less than the other injections, and we'll go in deeper and hopefully act better. But let me tell you, I remember very clearly when Allergan came out with Ozurdex, their first study said 6 months it will work. By the time the highest number of injections was done at Shankardev Nethralaya by Dr. Harsha Patel group and at PGI Chandigarh, asking both of them, they had done hundreds and we had not even started. Like Dr. P.K. Saraf said, I'll wait and see what others do. Or Dr. Kapoor said, I'm also hedging and hawing and waiting. So all these studies which come up don't live up to them all the time. Eylea was supposed to work for 2 months. It doesn't work. We all know that. I am not passing a judgment on brolucizumab or the Hawk and Harrier study, but like we said, real world data differs. 400 cities, 400 sites. The only one thing here is, this is a good study. Why for me? Because they did take in very large CNVMs also. Most studies are so tailored for giving good results. They take patients with very good vision, very, very small CNVM, huge number of exclusion criteria. So your results are bound to be good. So this study appealed a little bit to me because of the variety of patients that they're taken up. And this is a very busy slide, but I'll ask you to, is Honorito there?
Yeah, I'm there.
Yeah. So can you see my pointer moving around?
Yeah.
Right. Thank you. So to make it easier for everybody, this is, Honorito, unmute yourself, please. Yeah. This is after the lower one, which Dr. Bibhuti said number of injections here is more. In brolucizumab, your number of injections is less. This is what he's showing in 3 loading, and then once in 3 months is what he's hoping for naive patients. He doesn't know what he'll do for his not PRN, what he's going to do. So this is one point we're trying to make over here is that hopefully in time we will need to inject lesser number of patients for our with Paganax. What is the study? It's a non-inferiority study. From Dr. Bibhuti did mention superior, but to what I understood, and I may be corrected, it's not far superior. Aflibercept results are not superior. Number of injections less, I agree. Cost-wise less, I agree. But I do not agree to the fact that it's far superior. So no, it's not. Their own results don't show such great weak at the end of 1 year or of 2 years. The number of the amount of BCVA change and things is not too great of a difference. It is mildly better. This seesaw thing is what they keep referring to all the time. The Novartis guys, I know they're sponsoring this, but it doesn't matter. They keep saying the fluid becomes less and more again and again. Then you end up having more fibrosis and vision drop. I don't know, I don't understand this very well, but this is what they're telling us about the study. And if they say we need to take their word for it, that the fluid comes and goes very quickly, you will have in the long term not such a great vision. I am moving ahead with the Hawk and Harrier because we've beaten that with that already. I loved this article which talked about, because I come from an era where there was no OCT. Believe me, I started practicing without OCT in 2001, 2, then OCT came along. Now OCT INVs come along, which Vedang does for me very well because he has a lovely OCT machine. Or the guys at Shushrut, I don't have one still. This is an article which really interested me very much, published just 2 years ago, where they have a artificial intelligence to do a volumetric analysis, to do a fully automated detection of macular fluid using deep learning. And the volume of fluid is quantified. The volume of fluid is quantified, intraretinal, subretinal, all sorts of places. And then they said they used it for anti-VEGF therapy and neovascular AMD. So basically, if you use this algorithm, you can check the amount of fluid, volumetric analysis can be done. It was used in the Hawk and Harrier analysis also. And here again, they showed that if you look at these two slides over here, this part of it, this is the Hawk on top, the Harrier below over here. And again, the sawtooth pattern was observed in aflibercept, incomplete fluid resorption. But mind the differences are not too much. I wouldn't read too much into this over here. Just to let you all know that people are working on this particular thing, whether it will come to stay in our machines or not. This volumetric analysis of OCT to look at the amount of fluid. What I remember telling my patients 15 years back was, see, CMT 420, now down to 360, you're better off. I wouldn't tell the patient anything else. Because I was looking at the numbers, the number game is what I was doing at myself. So to sum up, the US approved this only in late last year. We in India got it in 7th of July this year. Superior again, everything sustained release. But like Dr. Bibhuti said, at the end of 1 year and end of 2 years, it seems to be working well. Number of injections seems to be less than aflibercept. And I hope we are proven wrong to think that it will work less. If it works once in 3 months, I'd love that to happen. I tried to change this slide multiple times. I know everybody has their own take on it, but I was not willing to accept what Dr. Subodh said. It's cheaper. Eylea now has this. I'm not sure how many of you are aware of this, but Eylea makes you buy the first one for 46,000, if I'm not mistaken. The second is free. Third patient buys. Fourth and fifth is free. So essentially, you get 5 injections for nearly 1 lakh. That's what I'm trying to see over here. 5 injections. Accentrics, this slide is wrong. For every 3, we get 1 free. So if you're doing 10 injections, patient has bought maybe 6, and the 7th one, you have 2 free in that. So it's not. But essentially, what again, Dr. Abhishek told us, Paganax is not very expensive if you take it in the question that you're giving it once in 3 months only. So this money part of it also is expensive, is not really true over here. Eylea has brought its prices down, so it matches up to Accentrics. Paganax also, if it uses it once in 3 months, it's fine for us. It's not so expensive. So what next? Anshuman has jumped the gun already. So in phase 2 trial is right now entering the phase 3. They are using brolucizumab. So this is not the last we've seen of it. This is, they are completing the study in 2020-2023 only for BRVO in macular edema, and they're comparing them to aflibercept again. So this is an ongoing study. And in PDR with laser, again, they're comparing brolucizumab. This is again right now entered phase 3 and finished only in 2024. So this is not the last we've seen of brolucizumab. They are yet to come. They're in the pipeline for these studies. But I would love Anshuman to do his studies and give us a quick pilot study in what he's done. I hope this video works. No, it didn't. Sorry. So I'll stop with that. My last slide was a thank you slide to all my colleagues, Dr. Rupak Biswas, Dr. Krishan Nandi, and SS Pal for helping me these slides. Thank you so much. I will stop sharing here. My moderator right now is Dr. Biswas is there. Rupakandi Biswas, please. And we'll keep this as short as possible. It's already 9 o'clock. Is Dr. Rupak Biswas there? Okay. Can I ask Dr. Satyan Deka, Arnab Das, Shalabh, anybody to take over Puja? Dr. Puja there? All bunking. Okay. Anita, can you take over? Is Shalabh there?
Good evening, sir. This is Himadri.
Yeah.
Just one quick comment, sir.
Go ahead.
Yeah, like you mentioned, sir, the real world scenario is very different. How long do you actually wait before you give the second injection in case of Ozurdex?
The Novartis guys are going to kill you and me. They're going to kill you and me. I am a paid consultant for Allergan, Ailia, everybody. So they're not going to kill you for this, but I follow up all my patients monthly, even after Ozurdex. I don't give them that holiday over there. So I inject 3rd month, 4th month. The moment I see it going up, I follow patients. And for Brolucizumab, I intend to follow them monthly. I don't give a damn. I tell them first day itself, it's a year-long, 1 monthly visit to me. I have no such holidays for them. I don't believe in letting my patients go.
Thanks a lot, sir. Thanks a lot.
Anshuman says, itching to say something. You want to get back at me?
No, sir. Absolutely not. I just wanted to bring a question of basic pathophysiology. Where aflibercept is different from all other molecules is that it also acts against placental growth factor, which is actually present only in disease state. It has got no function in physiology. Whereas all anti-VEGFs are working on VEGF, which has physiological as well as pathological roles. So sooner or later, someone who is in research should come up with something comparing the inhibition of placental growth factor with VEGF, which is done by aflibercept, versus only VEGF for a long time by brolucizumab or similar molecules. I am not aware of any study which has compared this till now. Just wanted to bring this up as a question of research.
I totally agree with you. Can I ask Nilutpal, please share your slides, please?
Yeah.
Is Dr. Ahmed, Dr. KK, I saw Kajulda was there. Dr. Kajul, sir, anything you would like to ask? Speak up. Professor Mishra, TNB, sir. I'll then close this session with the stock of mind. Can I invite Professor Abhijit, Ghosh, and Dr. B.K. Sharkar for the next session? Chairperson, Dr. B.K. Ghosh is there. I welcome, sir.
Okay, I'm here.
Yes, sir. And along with that, Subhendu Ghosh, with sir, and Dr. Vivek Dotto, welcome to the session, sir. I'll ask Dr. Anita Maiti to please go ahead with the presentation.
Yeah, thank you, Saurabh. Well, it's a small case. It's the first case of brolucizumab in wet AMD. This was a 68-year-old male patient, a doctor by profession, had a history of blurring of vision since last 5 months, could not specify the eye which got affected first, and associated with distortion of vision since last 2 months in both the eyes, known hypertensive and was on medication, no other significant history. On examination, the best corrected visual acuity in the right eye was 660, and in the left eye it was finger counting 2 feet. No other significant finding. What was noted that there was no inflammatory signs in the anterior segment as well as the posterior segment. the dilated fundus examination showed a bilateral CNVM. And as you can see, the OCT in the right eye, it showed an active CNVM. The central macular thickness was 341 microns, and the left eye, clinically, it was a partially scarred, little bit advanced. Most probably, this patient had a left eye involvement first. Actually didn't, as he was having the right eye normal, he could not appreciate the difference. In the left eye, the OCT is showing partially scarred CNVM with the SRF, the central macular thickness, the CMT is 421. So the patient had to go a bilateral anti-VEGF, and the option was given to the patient. The left eye, I advised him eccentrics, and the right eye, actually, I gave the option. The patient made Medico. I explained that this is a new medicines, and it was a choice between the Eylea and Paganex. And the patient chose Paganex, and obviously I was also keen to start my first case, and I wanted to see how this new drug behaves. After the injection, the first post-op day was absolutely fine, no inflammatory signs. Patient didn't complain anything. And this is after a month. You can see the post-op OCT. The vision actually improved from 660 to 636. The patient was symptomatically much better. And we can see in the OCT as well, the size of CNVM been reduced, and the CMT also reduced from 350 to 285 microns. In fact, today I gave the second dose to this patient, and the left eye also actually with the eccentrics has reduced the size. The lesion size is reduced, and the SRF has gone almost, and the CMT reduced from 450 to 330 microns. But left eye being a little bit advanced, the vision didn't improve much, although anatomical improvement was there. So the take-home message, obviously, brolucizumab had showed improvement, decreasing the intraretinal fluid, the subretinal fluid, and the central macular thickness. And according to the FDA-approved regimen, it is 3 monthly. So following that, I have given the second dose today and plan to follow up every 3 months. And obviously, reduction of injection frequency will be good for the non-compliant patient, but we need to see the real-world scenario, and that will give a good idea about the safety and the effectivity of this new drug. Thank you.
Thank you so much, Sudipto. Can you mute yourself, please? I'm told that because of you, it's causing anyway. Dr. Siddharth Ghosh is there. I saw his name.
Yeah, I'm there.
Thank you so much for being with us.
Yeah.
So, your panelist, Dr. Abhijit Barman, is also there. Zahir is definitely there. Pranab is there. Bikram is also there. I'd like you to involve all of them, and of course, Professor Ghosh, Professor B. Kishakar, and Dr. Boito, and the Dr. Sir. Dr. Boito, please go ahead.
Yeah, firstly, there are a lot of things. This is a very interesting case where two eyes receive two different anti-VEGFs. Now, the first thing, like what you had, Dr. Saurabh had discussed, like it's a small molecule. Now, this small molecule might have a greater penetration, and can we really expect much more penetration systemically? Like, so if systemically it's the levels are high, can we really expect more reaction, both adverse reactions as well as reaction to cross reaction to other anti-VEGFs, or what we are really scared of, these uveitis and vasculitis? Well, any inputs from our panelists, Dr. Barman, Dr. Abbas, Dr. Pranab Das?
Siddhartha, systemically, a good part about this drug is that it has the least half-life in the body. Yeah. It clears up, and perhaps the least concentration, and clears up most rapidly. That is a good part. So we may not be having that much of a risk as compared to others. But if we compare about the number of injections used in the Hawk and Harrier, in aflibercept group actually received, by rule, it received one injection every 2 months. So there was no way we can say that it has brolucizumab received less number of injections, because it was designed like that. There was no way one can alter the aflibercept. When those patients who were doing well, we could not have reduced the number of injections in those patients. So it is not quite possible to say that the number of injections were used. But yes, brolucizumab did have a much more drying effect on the retina. But again, if you look at the visual acuity gains, it was almost similar between the two groups. Now, my only question is, drug works, there is no point, no discussion about that. But when I'm telling the patients about this new drug, they are all asking about side effect, because right now about this vaccine thing is also going on, and this is also a new drug. They're all asking what can be the side effects. Now, there is, will it be proper to not tell them that about this 1% side effect and go ahead and give and tell them that no, this is a wonderful drug? Because whenever I'm opening my mouth about this 1% risk of uveitis and all, it is immediately becoming a no. All 6 patients whom I had offered, they are saying it no. But if you go into the Hawke and Harriet trials, they have not highlighted that much that this is a kind of this great amount of risk is there. They have, in a way, they have said it has been well tolerated and all that. The difference was only 1%. Aflibercept group was less than 1%, and this group was 1%. So that is the only dilemma I think that I am facing in using this molecule. What should I counsel? Should I tell them or should I not tell them?
Jahir, one question, one topic. Injection ranibizumab, initially it was when started, there are some literature shows that is the cardiac ischemia is a contraindication for ranibizumab.
Sir, at that time there was no other alternatives. Actually, only alternative was Avastin.
No. Nowadays, what percentage of the patients you have seen in your practice, those who developed myocardial infarction after giving ranibizumab?
Sir, they have very less, but it is very difficult to link the two events, because many of them have systemic comorbidities also. So it is very difficult to link. How to link that after giving the injection patient developed, because they were all hypertensive, diabetics and all that. So
diabetics must mostly associate with hypertension most commonly, and
yes,
diabetic hypertension, these are the comorbid disease. So these are the condition where we are using ranibizumab. But still in our RIO, we are giving 4,000 cases of ranibizumab. Many, one of none patients have not seen by myself to develop any myocardial infarction. Still, there is initially to start any drug with the systemic side effects that when explained to the patient, they will be very scared. So that after your experience, after finishing such experience, then you can definitely see some good effect.
Okay, sir, but
right,
what
that's
to
a very interesting this question of penetration. See, this is a very interesting case. Dr. Maitri had shown that both eyes had CNVM. So did you observe any change after the first eye injection, the right eye injection? Did you see any change in the left eye even before treating it with anti-VEGF?
I think that's asking for too much.
No.
Yeah, that would be interesting, because
take one,
systemic
get one
absorption.
free. Take one, get one free.
Yeah, it might have worked. Like, we need to observe that.
The question Aniruddha Siddhartha should be asked is that why did not give the Pagenet for the other eye?
No,
and this for the other eye?
I had decided the left eye eccentrics because the clinically we could predict the prognosis is not very good. So given advice from eccentrics, and the other eye, definitely that was the only eye, so I wanted the Eylea, and the patient was given the option of Pagnex. The patient had chosen.
So basically you cannot equate between the two eyes in your case.
No.
Okay. I think it will be interesting to note.
Siddhartha, you are muted.
Yeah. I think it will be interesting to note when you go for the second injection, because the other eye has received eccentrics. Now, whether this patient reacts when you inject in the right
see,
eye.
I have given the Pagnex today itself.
And Dr. Manav Burman is also there. We would like to have his inputs on this situation, this kind of a situation, bilateral CME.
Dr. Zahir Abbas has already nicely given that comments, so I don't have much to add to it. And it is now the right time to compare aflibercept with brolucizumab. Maybe after a few months or years, we can compare the efficacy of both the drugs. So at this moment, we should use brolucizumab as brolucizumab only, not as a competitor of aflibercept. That is only my comment.
Rightly said.
Yes.
We rather need to look at adverse events and be more sure about the good effects of the drug. And any comments or questions from Dr. K.P. Boyddo? Dr. Boyddo, your comments?
Yes. Personally, still I have not used brolucizumab because most of the this publication has been made from the Europeans, and on the Indian people, how does it affect the brolucizumab? Still, it is not there. So basically, from my side, this isolated cases those have presented, but actually we do not know the long-term effects, especially on the Indian people. So basically, I am waiting for the complications and etc. In future, and keeping on that. And basically, this is my idea. So, and the second thing is the regarding the complication, etc. So basically, in all anti-VEGFs like biosimilar and ranibizumab, they initially found this uveitis and the other complication especially, but that is it is accepted. But here also we have to accept that. But if we do not give so much importance on that, as Zahir Abbas said, he is scared of giving injection. So basically, we have to look forward. Exactly, we have to see what is the long-term effects, especially what happens to our Indian population. Actually, the most of the R&D happens in the European peoples. So might especially in Indian people, the choroid and etc. to some extent anatomically and pathologically different. So basically, this study should be made on that.
Yeah, thank you so much. And I would also invite comments from Dr. Samudra Ghosh and Dr. Vivek Datto if they are there.
Siddhartha?
Yes.
Can you hear me?
Yeah, please go ahead.
Acha, I just wanted to ask you if there's any information about the incidence of the adverse effects after how many injections of this brolucizumab. Mostly we have seen the adverse effects. Is it after the first injection or the second injection? Like any information you have, and I think, and we should, in our scenario, we should always think about brolucizumab as an alternative drug. In cases where it is not responding to eccentrics, we can think about brolucizumab to start with, and to see because it is definitely more effective, and we have to counsel the patient that there is a slight possibility of adverse effects, very minimal, like it's possible, very slight possibility, but that can be also rectified with proper treatment. So we should be very vigilant.
We must not confuse our common sense with scientific data. There is no data, there is no publication, Vivek, still to say it works better than anything else on recalcitrant recurrent cases. The only publication it works, how it works in naive cases. It's our assumption that it will work better in recalcitrant cases. It's Anshuman's assumption that it will work in diabetic patients. So these are all off-label users. Now, does that make sense in India? No, it doesn't. Because what is off-label in India is you as a clinician deciding what is good for the patient. But if you and me discuss about science, there is no evidence still to show that brolucizumab works better than ranibizumab in recalcitrant cases. There is no data to show brolucizumab works better than Eylea in recalcitrant cases or recurrent cases. The only scientific randomized clinical trial that we have is the Hawk and Harrier study, and that has not talked about this. So let's personally feel as physicians to what is available data scientifically. We should not confuse both of them.
But would you think about giving it as a first line of treatment?
Subhendu gave it to this patient. You missed the first presentation. He gave it to this patient first line of treatment. His first case, he did it as a first naive patient he has given with good results. And why not?
My patient was also naive patient.
Yeah.
Vivek, the first part of the question regarding that inflammation, the time frame, in the studies they have shown that it can come in the second or the third visit also. There are patients who had come with the second and the third visit, they had inflammation. So I think that time frame is very difficult to say. I think the time will say.
So, Siddhartha, if you can
I think if Dr. Samudra Ghosh is not there, then I would request Dr. B.K. Sharkar and Dr. Abhijit Ghosh to sum up the whole case.
Well,
you have to unmute yourself here.
Well, as is of Siddhartha of a new molecule, it has to be time tested. There's no doubt about the fact. As what we have gone through, the advantage is its periodicity. You give quarterly injections. That is a big thing which happens. But in all molecules, we're in a very primitive stage to judge now. Unless we use it ourselves, we can't say. So let it have a good future, I suppose.
Thank you, sir. Dr. B.K. Sharkar, sir,
how could you do the time testing if you don't use it? You got to use it. That's the primary thing. You have to convince the patient what's the problem. You cannot do the testing without giving the injection.
I'll sum it up here. What Professor Ghosh has said is beautifully said. And Dr. B.K. Sharkar is please devil's advocate here. I will allude to a drug forgotten by a lot of the younger people have not heard of it, which all of us have used, Macugen.
Yeah.
It has not been around for 10 years now. It came and went. So if it doesn't live up to it, it won't live up to it. So Abhijit Ghosh said, I agree with him wholeheartedly. I agree with Dr. Sharkar also. If we don't use it, we will not know it works or not. And it's time we start collecting Indian data. Dr. Professor Boito said, let's have an Indian data on this. To allude to Dr. Boito's statement, there are ongoing trials for diabetic macular edema with brolucizumab in India in 8 centers. They've done a couple of 100 injections, and the number of, this is again unpublished data, outsourced by me from somebody else, from a few of these centers, and they've not had any infections as such. No untoward report incident. Of course, nobody's supposed to share this data. If you're doing trials, you cannot share this data, but I can tell you this is what they've shared with us. But they've not had. 8 centers in India are doing a diabetic macular edema in brolucizumab as we do today. So I'll take what Dr. Sharkar said and Dr. Ghosh said. We have to use it, but we don't know whether it will go the Macugen way or it will be there to stay as a savior for us once in 3 months.
Absolutely.
Thank you so much.
Thank you.
Can we move on to the next presentation, please? My good friend, my colleague, Dr. Nandi, Krishnan Nandi is there?
Yes, sir, I am there.
Yeah. Any share your slides? Is Dr. Devdulal there?
Yes, I'm here.
Thank you, Devdulal. I'll just welcome you, senior consultant at Disha Hospital, along with Dr. Shangmutro is broken a tooth. She is not there. I didn't see Swarup. I hope he's there. Debashish may not be there. Santosh is definitely there. Kumar, Saket, and Vishwanath. Welcome all of you to the presentation. Krishandu will present his case, and Dr. Devdulal will. Okay, Anirudh was leaving us for another meeting. Excuse us. We are excused, sir. Thank you. Devdulal will please moderate the case. We'll try and keep the last 2 presentations as usual, running short of time to keep it on thing. Thank you so much. Krishan, go ahead.
Yeah, hi. It's my honor to present in front of such stalwart gathering. And I'll be presenting 3 different cases. I have given 3 brolucizumab injection. So I'll be presenting 3 cases. The case 1 is a 69-year-old male. Has a dimness of vision in the left eye for 1 month. Patient has a history of being treated in the left eye with the other anti-VEGF 4 years back. There is no systemic problem. Presenting vision in the left eye is 636 N18. So if you can see, this is a fundus picture of the patient where the center portion is scarred. Probably the patient was treated for CNVM 4 years back. And if you can see, there is a recent bleed just adjacent to the scar. If you can see the FFA, there is a almost staining of the dye, as because when you see the OCT, there is a some amount of fluid and the CNVM. So it's a recurrent CNVM, and because of the fresh bleed, we plan to give injection and give injection brolucizumab. So this is the after 3 weeks, the patient, there is a decrease in size of the CNVM, but some amount of cystoedema still persisting. Vision has improved to 618. So I thought to wait for a moment and re-inject the patient again after seeing the patient again after 2 to 3 weeks time. So this is my first case. Second case is a naive patient. Vision in the right eye is 6/60. Patient having CNVM in the right eye. And this is the OCT picture where there is a multiple cystoid space and CNVM. Given injection 2 weeks time, out of my surprise, there is almost scarred CNVM, an area of some amount of geographical atrophy, it's total scarred. So I'm now afraid the patient can land up having geographical atrophy if this amount of scarring happens to a naive patient. So this is the second case, 2 weeks follow-up only. So I have asked them to come after 2 weeks again. And third case is also a naive patient. Left eye is 636 vision, having CNVM. And this is the CNVM with the cystoid space. And after giving brolucizumab, this is totally drying up. And again, I have asked the patient to come again after 2 weeks time and repeat the OCT to see what happening next. Thank you.
Okay, great presentation, Krishnendu, as always. Am I audible?
Yes, sir.
So, regarding the first case, so well, the patient of course did well. The second case, would you qualify it really as a geographic atrophy at this point of time?
No, not now, but see the amount of scarring. If you see this scarring, there's so much of scarring in a single injection. I have never seen before in 2 weeks time.
Krishnendu, do you have the other sections? This,
no, I don't have.
Something strange happened between the previous and the second one. What is this bunch up? How did it become such a large scar?
Yeah,
This
this is out of my surprise it has happened. I mean, I have never expected this patient to react this much.
Yeah.
And well, you have to really follow up this patient. There could be
I'm little afraid.
RIP also can happen, and if the RIP happens, it's just below the fovea.
Yeah, just below the fovea. And CNVM, if you see the CNVM component, it is still there. It is still there.
Yes.
But so much of drying, I have never expected the patient to react like this.
But
was it done in the same machine? Because it will register the points.
Yeah, it is same machine.
Then it will be the same section maybe.
And vision gain happened. What was the pre of vision?
Gain. Yes, patient has gained vision, but I am afraid the patient is going to lose again.
So just to soothe your nerves, kind of, any fluid is bad. So you have had drying up of this patient and vision is improved. So let's hope for the best.
Yeah.
And let's go to the third case.
This has reacted very well. This is a good patient.
Yeah. So I think the pertinent questions that I think Kshitij wants to know is, so one is there a consensus on what kind of a follow-up we are going to do? Well, Dr. Saurabh Sinha just mentioned that no matter what is the injection, all injection patients actually need to be followed up every monthly, definitely. And, a 2 week time or a 1 week time post-injection is a good way to, go forward. That's one. And regarding how do we actually tell these patients, regarding the inflammation part? Well, I think it's if we consider the real world data that we have now, say out of 40,000, as Shutanay told us, 14 out of 40,000, if I remember right, So I think that's what should be portrayed, and it is kind of something similar to what we actually have in other anti-VEGFs also. So I'd like to get Dr. Saurabh Sinha to have a comment here maybe.
So I told a patient of mine last week that this is started just 2nd of I think November, 2nd of October. No, 2nd of October. We started in 2nd or 3rd of October. 1st of October started in India. So I told a patient of mine, a few hundred have happened in India, and one patient had some reactions. What I told my patient. That's the truth. I can't convince about 1 in 10, few 1 in 10,000, and I don't know. Like Kashitiz has asked twice. He's asked whether we should spell out intraocular inflammation. Now, how many of your patients are aflibercept? I have a question to Kashitiz specifically now. Have you done little research on aflibercept, intraocular inflammation? You'll be aghast about the publications that are there. The end of endophthalmitis, this published idea is freaked out. How many times you tell them that? Kashitiz is there?
Yes, sir, I'm there.
So, what do you tell your idea patients?
So just a routine side effects like vitreous hemorrhage, endophthalmitis, that's all.
So who's freaked out here, you or me? You are the patient. So I agree with you. It's very easy on a discussion like this over here. I take your word for it. So possibly we need to have some consensus because if patients jump doctors here in Calcutta, they need to hear us say the same thing. I agree with that, what you're saying.
Maybe with time, this thing about the serious adverse events, maybe with time people will grow out of it, and we will stop talking about this adverse events. And
people is us only. People is us only.
I feel we should always tell the data that we have. People might get scared initially, but when they know the real thing, someday they will know what is the published data. So we need to tell them straight away. As Dr. Zahir Abbas had said, that patient got scared. They will get scared, but eventually they will know what it is.
Dr. Nilutpal Borah, sir, yes, sir. Please.
No, it is. I think it is always better to be cautious about a new drug like this corona vaccines, or the way corona behaves all over the world. It's different in India. So similarly, whatever data has been presented in Hawk and Harrier, it could be different in India also. So I think we should look at the Indian data, and I would like to know from the panelists, they have injected many injections, whether any one of them had any kind of other side effects apart from the scarring which has been presented here. Saurabh, do you have any experience of any?
No, whatever I spoke to people in Bangalore, Bombay, as of now, nothing. As of now, touch wood, nobody's had any major experience. Santosh is there? Just one second. Santosh, please speak up.
Yeah, this intraocular inflammation part, I think it is not unique to brolucizumab alone. So it can happen to any injection. So when we are discussing with the patient, should we really stress on the intraocular inflammation? I think it is written to.
I think one way to look at it is, it's just like any other anti-VEGF. Any other
yes, that's it.
Have, inflammation, or it could be for some other reason also. So I think we need to look at it from that point of view and take it forward.
And similarly, we have to discuss with the patient, not to just focus on this adverse effect, which is very rare.
Let's look at the good side also.
I want to say one thing.
One second. Zahir, one second. I'll ask you the question only. I remember correctly, Dr. Nilutpal was saying he will see the patient after 3 months after the injection. So I'm asking you, Zahir, specifically, if and when you give the injection, how 2 weeks later I agree, 1 month later I agree, doing well like Krishna's patient. When
Sir, I could not hear.
Yeah. Can I ask Dr. Pooja to Bhavania to please mute herself?
I'm not gonna tap to speak.
Yeah. Yes. Thank you. So Zahir, my question was, if you have a first patient who inject, you call after 2 weeks, you call after 1 month, doing well, will you call again a month later or 2 months later?
No, I will follow the Hawk and Harrier. I will give 3 loading doses. because the good result that was seen of 3 monthly, it happened because we had given 3 monthly doses. If we straight away switch to PRN, these results we may not be getting extrapolated. And follow up, yes, every 2 weeks, even after the third dose.
Then you're not following their, they're not following their recommendation.
Oh no, I have to, for my sake, I have to follow every 2 weeks.
So what is credibility you will take up, what is not, will not take up. That's what I'm saying. I agree with you. I agree with you. I wholeheartedly support what you are saying. I agree with you. Better safe than sorry. Saket is there.
I have something important. See, any one of our colleagues who are giving the injection, they are taking risk and giving it. If suppose, God forbid, any of their patients have a problem and they do go to other doctors, we all VRSW members should be united in at least saying that this is nothing wrong that he did. This can happen with other drugs also. This is something we should all be, because one freak comment can lead to a disastrous consequences at this situation.
Zahir, 1 second. There's an excellent comment from Dr. Guha Thakurta. He says, patients sit here clued in. Once you advise this, most Google it and check what you have told them. So Dr. Google is superior to you and me. So let's stick to Dr. Google's recommendations also. Okay, I have one more presentation. Is Dr. Saket there? If he's not, we'll move on to the next one.
Saurabh, I am leaving. Huh?
Thank you so much, sir.
Thank you, sir. Thank you.
Thank you so much for being with us. Thank you. My sincere gratitude to you, sir.
Thank you, sir. Okay.
Is Dr. Sandeep there? Sandeep?
Yes, sir. I'm here, sir.
Yeah, Sandeep, can you share your slide, please?
Yes, sir. Good evening, everyone.
Yeah. 1 second, Sandeep, 1 second. Just hold on a second.
Okay, sir.
Devdura, did we miss anybody? Vishwanath is there?
Yeah, Vishwanath is there. Vishwanath, any comments? Vishwanath, any comments from your side?
Sir, I went into brolucizumab basically by compulsion. I have given 2 injections and both were on patients who were not responding very well to ranibizumab. And that is why I shifted. Eylea was a choice that I had given to my patients. Considering the economic factor, both my patients chose Paganex. So that is how I have given both my injections.
I totally agree with you. And I must again say that the informed decision that you have taken on behalf of your patient is not based on any randomized clinical trial. It is based on our analysis of what's going to happen. And I totally agree with you. What Krishna's patient showed us, what you are telling us, and how have you followed your patient a month later? Have they come back to you?
So I am going to see the first patient tomorrow.
So Shuktana, we must have a meeting again after 2 months to tell us what you all have done.
Yes.
Thank you, Vishwanath, for sharing that with us. Thank you so much. Anybody else is there? Have we missed anybody? Shall we move on to Sandeep's presentation? We're already beyond time. Sandeep, shall we go ahead with your presentation, please? Himadri is there, I know. Shantanu, I'm not sure. Shugato is there. Somnath is there, I hope. Shomak is also there, I hope. Sandeep, please go ahead. We can see your slide.
Am I audible right now?
Yes, yes.
Okay. Thank you. Good evening, everyone. Thank you, sir, for kind introduction. And I'll just start my presentation. I think it would be a different one than others for right now, because it's a lost it's a case presentation of lost follow-up, basically. So a case history: 76-year-old male, history of DOV since last 4 years, was diagnosed to have right eye AMD, left eye CNEM. Left eye intravitreal injection Lucentis was done in US in 14/3/2016. Patient underwent intravitreal injection Lucentis 10 times in various hospitals prior to visit to a hospital. BCV at first follow-up to our hospital, it was 69 and left eye 636. Patient was advised injection Lucentis for the same and oral antioxidant for the other eye. So this was the injection in between. I don't have much more OCTs because I can't recover the data from the patient actually. So these are the serial OCT of the follow-up while giving injections. Patient was following me up regularly. So patient was on regular treatment as advised till February 2019. Patient was maintaining his vision to 6.9 and 636 parts with a certain amount of subretinal fluid. And then patient lost follow-up. And then came again after 4 months with DOV and submacular hemorrhage, subretinal hemorrhage with best corrected visual acuity fall down to 3/60 in left eye. As you can see that there is a submacular and subretinal hemorrhage in the OCT fundus photo. I advised him intravitreal injection, eccentrics, 3 doses, and then I followed him with treat and extend regime. So these are certain his post-injection follow-up visits, OCTs, as you can see. And as time passes down, scarring occurred of the retina, but there was certain amount of interretinal cystic spaces and fluid still maintained. So I asked him to take injections as a protocol, but at that time COVID-19 lockdown occurred. Patient lost follow-up again, and then came again with DOV and fresh areas of submacular bleed with 2/60 vision in October 2020. This time I advised patient brolucizumab. Pros and cons of injections were explained to the patient and to the relative. They were ready for injection because they found it more cost effective because they had to take eccentrics each and every month or as per required. So they chose this option. So I followed them up. This is a pre-op injection OCT, and this is the fundus photo of the same. And follow-up patient gained 5 letters within first week of injection with no systemic adverse effect, no ocular adverse effect, and with the stable IOP. Patient is still maintaining 5 letter gain even after 1 month of follow-up with the scarring of tissue. And more patient results are still awaited. So this is the post-injection follow-up OCT of 1 month with quite good maintained vision, and further vision improvement is not expected due to the scarring of the tissue. So my take-home message: COVID-19 has changed the world. All patients can't afford treatment cost and monthly hospital visit. We need to accept this normal. Brolucizumab 12-week dosing reduces the patient hospital visit and is cost effective. Inflammatory and occlusive episodes have been noted in certain group of individuals. So for that, proper screening of patients is more important before injection. Thank you. So I'll stop my slide, and I thank you all for kind hearing. Thank you so much.
Thank you so much, Sandeep. Very nicely presented, very nicely put forward. I'll ask Dr. Himadri is there. Yeah.
Yes.
Himadri, please go ahead and discuss the case along with Dr. Shantanu. And
yes. So one question is, why did you suddenly decide to switch? Because the patient was responding pretty well to the previous injections. He was lost to follow-up, of course. But why did we decide to switch the injection?
So actually, the one thing was that a lot of eccentrics or Lucentis patient was taking, and as you can see, till 2019 he was on regular injections. Then he just stopped injections. In 2019, he was having 624, 636 vision. Then he stopped. Then as the vision drops to 3/60, he came back to me. So the time period of from 636 to 3/60 vision loss and everything, we lost the vision of that patient. So I asked him, better don't worry for the costing effect. There is more cost effective thing right now available. That is a brolucizumab that you can take 3 monthly. And patient was really 76-year-old. So he's an old guy. He's not really ready for hospital visit, frequent hospital visits. So I advised him, it's better that you go ahead with the brolucizumab for the long-term treatment.
Okay, do we have Dr. Nilutpal sir here? Dr. Somnath Chakrabarti sir? Dr. Somak Majumdar?
Somnath sir is here.
Somnath sir is here? Yes. Sir, your comment, sir. Are you convinced that we needed to change the injection from eccentrics to brolucizumab?
I think Sandeep has a point in that the patient is unable to come frequently, which is genuinely a case now with all the corona problems. And there are some, like for example, the neighboring state of Sikkim is still having a lot of traveling restrictions, even though now we are in unlock mode. So I think it's fair enough to try this drug. Definitely, it has a longer effect, longer lasting effect. So the idea seems quite acceptable to me, and it has also enhanced effect. So let's see if it can keep the macula dry for long. It will be good to know, what happens to the patient in the long term from Sandeep.
Dr. Saurabh Sinha, sir, sir, what I'm hearing from all these discussions is we have established non-inferiority till now, but have we actually established that it's better in any way?
No, we are confusing a lot of things over here. Sandeep's presentation also he ended giving a take-home message. Again, we are confusing. I keep saying we confusing two things continuously. One is published RCT and our own understanding the situation.
Yes.
So Sandeep says he switched because it's cheaper and it's once in 3 months. I accept that. I totally accept that. His thought process, his contribution is fine by me. What I do not accept is how does he know that this particular patient will last for 3 months? He has no data for that. He has data for that for naive patients who have a 3 loading dose and then follow up. So we're confusing data over here.
Yes, yes.
Scientifically, smaller size goes in all the way. I would strongly suggest that those who are starting, and Sandeep, don't get me wrong, I'm not questioning your ability as a clinician, but this is a new drug, like Professor Abhijit Ghosh said, you need to use it, but follow up monthly. I agree with your old patient, I agree with your thought process, and what Somnath proved, what you just did, I agree with you wholeheartedly. But we are confusing data over here. A naive patient, 3 loading dose, then follow up 3 monthly is different from a recalcitrant case, recurrent case, no treatment for 6 months, and then 1 injection doing well. I'm not buying that.
I'll follow up, sir. Obviously, thank you, sir. I'll follow him up every month. I'll call him.
I think we already discussed this because we are confusing the published data with what we are going to practice. I possibly totally accept what you just did.
So we definitely need more experience with this newer drug, but we really are spoiled for choice now because there are so many drugs in the market. We actually really not know which we should start with.
Is Shantanu there?
May I say something?
Please go ahead.
Latest, after the COVID thing happened, the insurance policies have changed. And that's important to us. And they accept intravitreal injections as a procedure that is important and that is valid for insurance.
Subrata, just to put it in perspective, that circular came out in September 2019.
Saurabh,
let me finish.
Okay, sure.
And again, 2020 June, it has come out as a master circular, which has been sent by VRSI to us 2 weeks ago. And it says specifically, like you said, you cannot exclude it from the treatment for the policy.
Exactly.
The IRDA has said that. So the IRDA is circular. So I totally accept what you're saying. It's cheaper for it's hopefully be better for our patients.
Exactly.
Yeah. The VRSI has sent out everybody, all of us on the email. And I totally accept what you just said. I give a copy of that to all my patients. I say underline that it cannot be excluded and ARMD is included.
Because that's important. Because it's expensive.
Very expensive. I agree with you wholeheartedly.
It's very expensive.
I give it to all my patients. Because I practice in which there's no cashless, so it's very important for me.
We need to think about this.
Yeah. Himadri, anything else?
No, sir. I think we definitely need more experience with this before we can actually start it in recalcitrant cases or cases where we feel that it will last longer. We definitely need more real world data as well.
Is Shantanu there, please?
Yeah.
Okay.
One last comment from you.
We are in a learning phase actually.
I hope you
We're all learning. No, we are all learning. I am waiting eagerly to see one vasculitis case. I'm really waiting.
What a spoil sport you are.
Just want to see what are the changes happen. Is it a normal vasculitis or? Absolutely.
So
I'm convincing.
You have one, treat it and tell us what to do.
We are waiting.
So I remember there was an ad board meeting in which we had some of these big people, Mahesh Shanmugams and Dinesh Talwar, senior people, and they caught hold of the Novartis guy and asked him specifically, we don't care how many happened. What I really want to know is, what did you do for those patients? Was it topical? Was it steroid? Was it Ozempic? Was it, did you vitrectomy? How many needed? What was happening? That data is very important for us. That is what we need to get to. And the Novartis haven't still come back to us with that. They are supposed to, as of this month, get back the data of that, what happened to all those patients. There's an ongoing body for that. So that will help you, Shantanu.
Yeah.
What is your hypothesis of why this is happening? Your hypothesis?
No idea. Actually, I have to see what kind of vasculitis is it. Is it a obliterative vasculitis or a simple, or is this a vasculitis involving both artery and vein, or only artery? What kind of vasculitis is this? So we have to know that. Right? For knowing that, it's very difficult.
Right. So,
will I be right if I say that in today's take-home message is number one, as far as I understood, is that people are already using it in India. The experience so far, it seems that we are not getting that horrible results or that kind of shocking cluster of cases like it happened in US. Also, as I understood, that there were a lot of cases here where it has been tried in a naive patient. So it's almost sort of becoming first-line therapy for a few people. So, as far as my understanding of the study so far was, there was no real need for us to start with that drug. Like, for example, in Subhendu's case, I think he was very brave of him. The patient had 6-12 vision and he still started with brolucizumab. Now, so what do you say? Like, what should be my take home? One is that it seems it is safer than we initially were apprehensive 2-3 months before people started trying in India. And you still feel that it is safe to start as the first-line therapy itself?
Actually, I can answer Somnath's question. It's better than the nightmare we have with Avastin. I think so, because Avastin is such a nightmare that time, 2014. I remember every day, every night. So it's better, I think. And we are learning. Let's see. Let's see what is going to happen.
To that, I would say that, okay, I think Avastin has been too maligned by few people. Unfortunately, I don't think the global experience is same. Maybe I'm just waiting to face that nightmare myself someday. Fortunately,
no. I totally buy what you're saying, Somnath. So Avastin is a lovely drug. I think it's excellent.
That's true. That's
for its cost, for its efficacy. I think it's fantastic. Let me not drive away from that. I am waiting for a intelligent patient like Dr. Subrata said, the Google trained person coming and saying, I want brolucizumab.
Exactly.
I'm waiting for that guy.
Exactly. Avastin was fantastic. It was the process that's the problem. Yeah. Not the patient, not the doctor, not the drug.
American son, patient saying, I want back in X. I'm waiting for that patient still. That will solve all my problems. I will not speak anything at the patient.
No, why not Avastin?
Why not? I agree with you. Why not?
Why not Avastin? Like most of I work in Howrah. Now it's stopped because of COVID.
Yeah.
But I work in Howrah. They can't afford all this.
I agree with you.
Avastin for 7,000.
Like I showed my slide, that red on top was affordability is always the biggest.
Absolutely.
Right.
That is important. But are we going to just work for the city population?
No. I work in interior Purulia and I agree with IBT.
Exactly.
Over there. Yeah.
So why not Avastin in a different form,
definitely,
which is purified and sorted?
Yeah. So I agree with you.
These problems are not with the drug; it's with the delivery.
I agree with you. Yeah. So
Avastin is the way forward. Honestly.
I have permission of the chair, Dr. B.K. Shakar and Abhijit Ghosh. Can we close the session? We'd like to thank Novartis as a vote of thanks. The Novartis guys and the VC Communication, thank you very much for all that you've rendered to us. My most important thanks to all our panelist participants, and a lot of you who participated today were not panelists. I'm really surprised, and thank all of you. I saw Dr. Arup Bose's name. I saw Dr. Bharti Kashyap's name. Thank you all so much. To go out also for turning up and with us. Good night, everybody, and let's.
Good night, all. Yeah.
Summarize this whole situation. Thank you so much.
Thank you, and good night.
Thank you. Good night. Good night, all. Well done. Well done. It was very important.